Thanks everyone for joining for another one of our intermittent Broad community updates on COVID. It's been about 2 months, so I guess it was time. And I'm calling this one the Are We in a Surge edition, because I think things have become a bit more complicated in terms of even telling how things are around us. So to give a quick overview, I'm going to go over where things stand in terms of the case trends that we've seen locally and nationally lately, and to mark a milestone, then talk about new variants that are emerging in the US and around the world, talk about some changes in masking recommendations that have affected a lot of us in sort of public life, vaccines in kids, fourth doses of vaccines, and then get to your questions, many of which will have been addressed in the above topics. So folks submitted some questions and I'll do my best to answer them, and then cautiously give a speculative look ahead. That's always the most humbling part of this. So let's dive right in the interest of time. And the first thing I wanted to do is just to note that as of yesterday, by some official counts, and certainly sooner than that by real counts, including missed ones, we reached 1 million deaths from COVID in the United States since the beginning of the pandemic. The official count in the world is over 6 million, but that's a gross underestimate. I think WHO just came out with an estimate that the true count is over 20 million, and maybe even 20 million higher than the official count. So somewhere in the 20 to 25 million range is likely the real death toll from this pandemic. And we'll sort of never know. I know that many of us know some of those 1 in a million or 1 in 25 million, and it's just a hard thing to wrap your mind around, but I wanted to acknowledge it. Where things stand right now in terms of case trends in the US, the Omicron wave came and swept through quickly, but really changed, rescaled all our axes, right? Changed what we thought of as possible. It's probably the fastest spreading disease in human history. Measles has a higher reproductive number, but a longer generation time. So in terms of going from first discovery on Thanksgiving, first report on Thanksgiving Day to the dominant variant throughout the world by Christmas, that's got to be faster than anything has moved before. In the US, hospitalizations reached an all-time high. Deaths did not quite reach the level they did prior to essentially any vaccine deployment in the winter of 2020, but did exceed the peak of Delta. But the per case hospitalization and death rates were considerably lower than before, I think mostly due to immunity and maybe slightly due to an intrinsically less virulent variant. But most of this is because we're accumulating immunity in our society and our world. And that made the impact less devastating than it would otherwise have been. It was still a very disruptive variant. And unfortunately, though I said it swept through quickly, we got a brief reprieve. Cases are clearly rising again, and I think likely faster than reports are shown. So if we look in Massachusetts, we cases are here obviously rising as well. We're at least fourfold up from our recent trough. And in terms of thinking about when have we been exposed to similar risk of seeing the virus, we're about where we were in mid-November 2020 in terms of case count. So that was, if you'll think back to pre-Thanksgiving, Delta was on the rise. We were just entering what is traditionally coronavirus season. There was a fair bit of COVID around. There is again a fair bit of COVID around, and that's just among cases that are reported. I think it's pretty clear that there's more testing being done at home. On antigen testing, and a lot of folks that may not be then getting that captured in data that's reported to public health. We are 9-fold down from the peak of cases in around early to mid-January. So that's at least still good, but we continue to be on the uptick, and percent positivity gives you some hint of the fact that we're rising, I think, faster than we are tracking in terms of cases. This has risen higher as a proportion of the Omicron peak than the total case counts. So because of that, I actually think that maybe one of the more reliable indicators that we can turn to, I did these in the wrong order, is wastewater. And that has proven to be a fairly reliable predictor of case trends to date wherever it's been looked at. This is a study that just came out within the past few days that kind of recaps the early parts of the pandemic. I think this analysis stops in mid-2021, but basically shows that cases in orange and wastewater measurements of COVID RNA in blue track quite well, both in time and in space. And so they don't rely on testing behaviors. And so I think maybe may give us a better sense of where we stand in a way that's less, affected by that sort of comparison. So if we look at wastewater in the Boston area, we see that rather than being fourfold up from our recent trough, we're actually sixfold up. So maybe we're missing, some fraction of cases anyway. And are equivalent to November 2021 still, but a little bit later in November, closer to Thanksgiving, if you use our wastewater abundance. And, it seems like maybe we're in a bit of a plateau if you sort of aggregate over the past month or so, but, you'll note that the last couple of weeks, there's another uptrend. So I think we still need to wait and see where this is going. We are about 12-fold down from the peak of Omicron, and that's actually more than we were from Massachusetts by cases. It was 9-fold down from the peak for cases and 12-fold from wastewater. But I actually think this may be a bit complicated by the really, really fast rise of Omicron may have led to sort of a synchronous shedding that may have made this peak a little bit higher than it was per case. So there's still some complexity to this, but at least this is a thing that I've been looking at that won't rely on testing behavior. And I think also clearly shows that, there's a lot more COVID around us right now in Massachusetts than there was, 2 months ago. And this happened faster, I will frankly say, than I expected in the wake of Omicron. I think, some combination of behavior changes and variants has led to more of a rebound than I hoped that we might get as we headed into late spring, but here we are. Another thing I wanted to mention, just in terms of thinking about case trends in the U.S., is to describe this recent study that came out in MMWR by the CDC on seroprevalence in the United States. This is based on, I think it's important to remember, it's based on a convenience sample, which means this is folks who are getting blood tests for other reasons. Now, those were not folks who were getting blood tests to test for COVID. They made sure to exclude those, but it wasn't blood draws specifically to try to assess the population prevalence. It was not a random sampling. It was just a subset of folks who were getting blood tests for other reasons that were sent to the labs. The CDC took some of these tests and tested them, these blood samples, and tested them for the presence of the nucleocapsid antibody. So this is not the spike protein, because that would be a sum of those who got vaccinated and those who had been infected. Nucleocapsid is not in the vaccine, so this should really only be positive in folks who have seen who have been infected with the actual virus enough to generate an antibody response. And while there might be some weighting of this, it's probably a pretty good aggregate measure of who's been infected before. And what you see is it's a really high percentage of people. And actually, the younger the population is in our country, the more likely they are to be infected. Kids in sort of school age years are up to about 75%, at least kids who got bloods drawn for some reason. You can ask how representative that would be of the kids in your life or of the general population. I think it's an open question. It's not entirely obvious to me how that would track, but changes over time should really matter. And what we see is that there was a lot of infection during the Omicron wave, but about half of that seroprevalence accrued after December 2021. So there have been a lot of infections in the last couple of months, and that's important in thinking about what comes next. So to summarize sort of where we stand with case trends, cases are rising again, maybe 4 to 6-fold higher in Massachusetts than they were at their recent trough, and which already never got as low as last summer. That we bottomed out about 10 times higher than the level that we got to last summer, both by counted cases and by wastewater. And locally and nationally, it's not clear to me at all that this recent rise has yet plateaued. Our wastewater may look like that, but there's some fluctuations that have caught my eye. And I think a lot of this rise has been a combination of things. I think it's hard to pin on just one thing. It has coincided with what I think are some pretty widespread behavior changes that you all have probably noticed too around us. I think maybe that's less true in some parts of the country that may have done this sooner, but at least in Massachusetts and the Boston area, we seem to have unmasked indoors more in the last month than we had previously. It also coincides with the takeover of some new variants. So BA2 replaced BA1 quite quickly, and more recently BA2.12.1, which I think is begging for a better name, has been displacing BA2, and sort of coincides with the initial uptick, and then that more recent rise we saw in the wastewater sort of corresponds with the BA2.12.1 takeover. So it remains to be seen the relative contributions of each of these, and actually I think is going to be hard to tease out, but it's happening. And there may be more on the horizon, which I'll go over in just the next section, which is sort of BA2 and more. So let's think about worldwide and US variants. In the US, BA2 already replaced BA1, which is kind of the original Omicron. And actually, we got kind of a subtype of the original Omicron, BA1.1, as the dominant lineage here, which is different than what South Africa saw. Then BA2 came in and swept. Cases rose a little bit as that happened and as behaviors changed. And now we're starting to see in the US, BA2.12.1 taking over. In the Northeast, it has already done so. So in our region, it is the dominant strain now and has been for at least a week. And, you know, we'll talk in a minute about what that might mean a little bit more, but in South Africa, BA2.12.1 didn't really seem to take hold, but instead they have two slightly more different variants, BA4 and BA5, that are starting to displace BA2 and take over. So alphabet soup, they do have mutations that are of note. In fact, some that are shared between these lineages that seem likely to cause more immune escape. But the overall implications, I think, are a bit unclear. I think it's pretty clear that they're going to extend transmission periods. I forgot to mention South Africa, in addition to seeing BA4 and 5, are seeing cases rise, and not only cases rise, but percent positivity rise even more quickly. I think they have the same kind of less publicly reported testing phenomenon seems to be happening there as seems to be happening in the US, but their percent positivity has risen sharply, coinciding with BA4 and BA5 takeover. So what will this mean? I think it will clearly extend transmission periods beyond what would have been possible in a sort of parallel universe where these variants didn't exist, right? Like, you know, a single variant will burn itself out through at least in part through population immunity, but these new variants arise because they can evade that. I've talked about this in prior, and so that means that we're going to see cycles of more cases, not just the one that we're in, but I think probably BA4 and 5 are likely to do that here too. I've posed this before. There are some key questions anytime there's a new variant that I ask anyway, which is how relatively transmissible is it? How immune evasive is it compared to prior things and compared to the circulating sort of dominant immunity? And then how severe is it in some intrinsic way, as best we can tell? Transmissibility is becoming both harder and harder to deconvolute from immune evasion as more and more of the population has seen spike and has been infected. And I think less and less relevant, honestly. I think all of these are going to be tremendously transmissible viruses. And I'm not sure subtle differences are going to be what really drives spread anymore with so much immunity in society. So I think it really comes transmission really comes down to immune evasion more than anything else at this point in the pandemic. And I think that will remain true going forward. And so what we know about these variants, I'm skipping over the data in the interest of time, but we know that BA1 it only incompletely protects against BA2, better than nothing, probably better than wild type spike, but not well enough to prevent infection, right? So BA2 escapes BA1 to about the same extent it seems that like beta escaped wild type, or prior variants before Omicron escaped our wild type immunity. There's some very early data in the past couple of days that suggest that the cross protection from BA1 against BA2.12.1 and against BA4 and against BA5 is even less than it was against BA2. So we are, not surprisingly, some more immune evasive variants are the ones that are starting to take over. It's important to note that vaccination helps. So a lot of these data are coming, especially the BA4-5 is coming from South Africa. The BA2.12.1, that data that I saw is from China. And in all cases, if you were vaccinated and infected with BA1, you had broader immunity and less evasion by these new variants than if you had only been infected with BA1. So, you know, I think that's important to remember, but the general point to take away from this is that immune histories are becoming more and more complex over time. This is true for individuals like you. Have you been infected before? If so, with what and when? Have you been vaccinated? With what kind of spike? With what variant? When? Have you been boosted? All of these things are going to diverge more and more from people, and even more than that across populations, where different variants will have hit to different levels and at different times. Different vaccines will have been deployed. And so I think it becomes harder and harder to project from one place to the next. But I do think that in this world, there are and continue to be more immune evasive variants, and I think we're likely to see some subset of them here. Relative severity, I think, is important, but again, as immunity becomes more complex, harder and harder to ascribe to the virus. I've not known all along how much stock to put in sort of cell culture and animal studies that have suggested that, for instance, BA1 was less likely to infect lung cells or the lungs of hamsters, right? This could be, especially the animal models, it could just be that it's getting better adapted to humans, but it looked pretty convincingly, even in human cell lines, that that BA1 original Omicron infected the lung tissue a little bit less well. And maybe that had something to do with its lower severity, in addition to population immunity, which I think had a larger role. I sort of hope that isn't true, because some of these new variants seem to be better at getting into the lung again. And I just think we don't know what that's going to do. I think it's possible that the intrinsic severity may have gone up again. with some of these mutations. But I think that immunity has continued to broaden. And so my expectation is that the overall population level impact of these new variants of each successive wave is hopefully going to get less as our immunity accrues. Certainly, we've seen no alarm signals that that's not going to be true in the places where this has been looked at early on. But it's early. And the other really important thing to remember is that what happens to a population is different than what happens to an individual. And what happens to you is going to depend on your immune status and to some degree chance. And these are all still serious viruses, right, that are potentially life-threatening. And especially if you are an unvaccinated and never exposed person, which is less and less of the world, but still some of the world. It's still 25% of our children under 5, for instance, or if you're immune suppressed. And that's simply how it is, and we don't really know how to predict how these new variants are gonna hit compared to the old ones. In general, I would sort of say that Omicron looks like it's a promiscuous scaffold. If I think of this as like a chemical scaffold that can be used to generate a lot of different functional groups, unfortunately, Omicron is sort of behaving this way, right? We saw some variability within Delta where sublineages were starting to emerge, but they didn't seem to have as big of an impact on spread as the sublineages of Omicron have had. Part of that is how long Omicron has been the dominant variant. It's going on 5 months now. But I wonder if, and this is a little bit of speculation, I think some of it is that Omicron is a scaffold on which a lot of different kinds of antigen, a lot of sort of different caliber of antigen seems to be, from which a lot of different calibers of antigen seem to be emerging. And I don't know how much more that's going to be possible, but there's no indication that we've seen the end of that yet. So we keep having these kind of rapid cycle waves in a lot of places. All right, I'm going to try to wrap up in the next 10 minutes or so go a little bit faster through the next sections, but I think everybody was aware of some changes in masking recommendations and the impact that has. And so I think some of this started with a judge's ruling and subsequent changes in what was permitted on public transit. And so I think in the end, we're kind of left asking ourselves, what does the situation around me look like? To get back to the title of this talk, are we in a surge? I think for my money, pretty clearly we are, in the sense that there's a lot more virus circulating in the community than there was. The CDC has 2 websites that allow you to kind of look at this, and they're quite different from each other. There's community levels, which I take to mean how likely is it that the hospitals around me are going to be overwhelmed. In other words, the color here has something to do with case counts in your community, but also those case counts are colored differently depending on what the hospital capacity is in your community. And most of the country is still in a good place there. It doesn't seem like we're going to be at like triage standards of care anytime soon, as we were as recently as the Delta surge, and in some places, the January Omicron surge pushed hospitals to the brink. Also, we don't look like we're getting there anytime soon, but there's a lot of COVID around. This map has changed from blue and yellow, which were lower, to much more red and orange over the past month. And this really is just a raw measure of the cases that are around you. So if you really want to know your likelihood of encountering COVID, as you might if you're immunosuppressed or live with folks who are, this is a better map, and it's starting, it's looking worse over time. I mentioned the recent court ruling that said that the CDC is no longer allowed to mandate masks on planes and public transit. The part about planes got a lot of attention, and I think rightfully so, especially given the way it went down and sort of policies changed in mid-flight for some people. But it's important to remember planes are actually pretty well ventilated spaces, at least when they're flying. There are times when they're not, when those ventilation systems are not operational. It's essentially anytime they're not flying. So boarding, even taxiing, and certainly on the way to and from the airport, it's worth remembering you're not in a well-ventilated space. But in the air, you're at greater risk from the folks immediately around you than you are in the rest of the plane. So the fact that you're trapped in with hundreds of people is, I think, a little bit less relevant on a plane, but it's a big deal on trains and especially buses. Those tend not to be well ventilated, especially when windows are closed. And many more people are on buses and trains every day than on planes, although for a shorter time. But I think the lack of ventilation is going to offset that. So if you are at high risk of severe outcomes if you do happen to contract COVID, or if you spend time with someone who is, someone had asked, should I keep masking on public transit? I do, I would. It is an individual decision. That is how our society that is where our society has come to. And then but I do. Just because I think it's very likely that someone, giving rates right now, that someone on your train car or on your bus, it has COVID, and ventilation isn't that great. The other thing to remember is, this was my first attempt at a Drake meme. I think I shared it at my in my last talk, but didn't dwell on it too much. But um, what masking, the fewer people around you mask, the more you need to, the better your mask needs to be, right? So a situation where you're wearing only a surgical or a cloth mask and no one else is masked is not that safe. This is not a situation I would expect would protect you from Omicron if someone near you has it. Both folks wearing surgical, everyone wearing surgical masks, that is better. That's like kind of how our hospital still functions, unless we're going in to see a patient with known COVID. The sort of default practice in the hospital is everybody has a surgical mask on. Your healthcare workers, they tend to know how to wear them, but that is still what we use in the hospital. But if you're around folks that are not masking, the better your mask, the less likely you are that you're going to get anything. And so I wear an N95 out in indoor public spaces now for this reason. Specifically, I found no brand, I certainly get no kickbacks on this. And this isn't an official, endorsement or anything, but I have personally found the 3M Aura and the Halyard Duckbill brands of N95 to be much more comfortable than like our hospital issued 3M masks that are of a different brand. And so these are the ones that I like, the 3M Aura. That's what I use. So I have next to me here. And then for our kids, for those who are interested, because like kids going on public transit have a much harder time. There aren't really N95s made for them. They may have a hard time wearing them. We have sort of KN95 type masks that we ask them to wear when they're out in public in high risk settings. So take that for what it's worth. And obviously we're in a place where everyone's making their own choices now, but those are mine. Vaccines in kids, there were a couple questions about this. I view this similarly to the way that I have all along for the sort of 5 to 11s, for those who have followed my updates before. I think COVID looks just like the kind of thing that we vaccinate kids for. This is a slide from the ACIP meeting where they unanimously approved COVID vaccines for 5 to 11-year-olds. This is shared by one of my colleagues who's actually on the committee. And this looks at 5 other recently approved childhood vaccines and the total number of deaths that they caused in the 12 months before the vaccine was approved. COVID is more than the sum total of those deaths. And so I think this is very squarely in the range. Even though 66 seems like a low number, remember the number of hospitalizations is hundreds of times higher than that. And this is also before the most deadly part of the pandemic for kids. This is just before the Delta winter surge and then Omicron. And already it was a top 10 cause of death for 5 to 11-year-olds. So this is, to my mind, of course, this is the kind of thing that we vaccinate children for. And by now we have safety data on billions of people with the mRNA vaccine platform, and now many millions of children in the 5 to 11 range. So what about our youngest? I have a 3-year-old. So I vaccinated my 6-year-old as soon as she was eligible. Literally every child of every physician that I personally know made the same decision. What about kids under 5? So I think the need is at least as great in the under 5 crowd as it is in the 5 to 11 crowd. In general, severity in the 5 to 11 is actually probably the lowest that is at any age. Maybe if anything ticks up a little bit in the less than 5 group. It also, based on some estimates that were recently shared on Twitter from CDC data, also likely a top 10 cause of death in this age group. It's actually surprising how hard it is to tabulate this, but it looks like even just the number of children under 5 who have died, so 1 to 4 years old who have died in 2022 so far would already qualify as a top 10 cause of death in any sort of recent year. So to me, this is again squarely in the realm of things we usually vaccinate children for. I find it very frustrating that 16 months after the first approval of adult vaccines that we don't have data in the public sphere on how safe and effective vaccines are for this age group. I think our approval system is not built for a pandemic that moves this fast. And in that time, 15 million kids under 5 have been infected. And that I find frustrating. So folks have asked me to go over the data. There really aren't data in the public sphere yet. There are press releases. And so what we know is that like most pediatric vaccine approvals, this pediatric vaccine was meant to be approved based on what's called an immunobridging endpoint, which means does it elicit the same amount of antibodies as the full adult dose elicits in adults, right? So you do efficacy studies in adults, and then generally you step down to kids because we know that kids tend to have fewer severe outcomes for almost anything. We tend not to require an efficacy endpoint for children's vaccines. We often will kind of extrapolate down and just say, do they elicit an amount of antibody that we know to be helpful? So that was what the original plan was. Pfizer had an initial readout in December and unfortunately missed that endpoint. We still don't know by how much, but they did. Their 2 doses of the Pfizer vaccine did not quite match their pre-specified threshold for the right amount of antibodies. It came in below that. And so because of that, it was kind of set aside. We recently heard that Moderna, based on their own press release, did meet their immunobridging endpoint, and they've recently applied for an EUA to the FDA, although from what I understand, that submission is not quite yet complete. And the FDA is likely to take that up soon, although it seems like it might be into next month based on the latest data that I've heard. We also, though, because this disease is so common, we have efficacy data too. And it didn't look great. It was about 40% for both the Pfizer and the Moderna. So I should add that Pfizer in response added a 3rd dose, and we should hopefully have a readout on that literally any day or any week now, but we haven't heard anything yet at all about that. Neither vaccine, neither Pfizer nor Moderna in this age group looked that effective, but it's important to remember we're now looking, so meaning about 40% protective against infection. It's important to remember that we are in the Omicron era now, though, where 2 doses of vaccines don't protect anyone very well anymore. And so this isn't a surprise. The other thing that's happened is, as I showed earlier, up to 75% of kids have already been infected, and 50% going into the Omicron era, 40 to 50%. And so even the unvaccinated kids are likely to have some degree of protection. That's going to cut into the measured vaccine efficacy. And so it's hard to extrapolate from this. And honestly, that doesn't trouble me much, because I think the ship has sailed on a wild type spike vaccine, really reducing infection by that much. 40% is about as good as it's going to get, I think. What I'm really interested in vaccinating my children more generally, is preventing severe outcomes. And we know that in the Omicron era, at every other age that we've looked, these vaccines still do a really good job of that. This is the single best visualization that I've seen of that, although there's a lot. But after many, so these are 2 societies, Hong Kong and New Zealand, that had very little COVID before Omicron showed up. Just because of control policies and what other mitigation measures. And yet both were overwhelmed by Omicron. It just became too much. And in New Zealand, the population is tremendously highly vaccinated, and they got a lot of cases. In Hong Kong, especially their elderly population is not very well vaccinated, and they got a lot of cases. In fact, a comparable number of cases in New Zealand. New Zealand saw almost no deaths, and Hong Kong saw a tremendous number. Actually, like this was as bad as New York at its worst, which is staggering in its own right. But we know at every other age group that we've looked at, the vaccines, even if they allow infection by Omicron, they prevent severe illness. There's no reason I can think of why that would not still be true in the youngest kids. We will never see it in a trial, because you can't do trials large enough to really follow that. And so this is exactly why we use immunobridging endpoints. And so I'm hopeful this will be approved soon. All of this is sort of my way of processing my frustration with the delays, but I am hopeful that that will be available soon. I expect that when it is, and when it's evaluated by the EU, by the FDA, and receives authorization, I expect to get my 3-year-old vaccinated as soon as he is eligible, just like I did for my 6-year-old. I will, of course, look at the data when it's made public before I do that, but I at least have not seen any reason to think I wouldn't take that course of action. Really quickly, 4th doses. You may have heard that those are approved in the US for everybody over 50, although only really recommended if for over 65 or high risk. This is largely based on a series of observational studies in Israel, where they were early adopters of 4th doses. They've kind of been early adopters of boosters as well. And what they saw, depending on how you report it, could sound really quite impressive, or maybe a little bit less so. But they found a 75% relative reduction in the risk of death in folks who got 4 doses compared to folks who got 3. This is like these are already, this group in blue is already pretty protected, but the group who got 3 doses, but the group who got a 4th saw a meaningful, statistically significant, and quite sizable reduction in their likelihood of death over 6 weeks. We don't know how fast that will wane. For the aficionados, there's a biologically plausible delay from that 4th dose till they saw the protective effect. So this doesn't seem to just be sort of selection bias against an observational study. So maybe health-seeking people or people who respect COVID more and are likely to avoid infection at all may have gotten it. But there was almost no protection for day 5 to 6. There's a little healthy vaccine effective, but then by about day 14, they see this sort of durable protection. And that's about what you'd expect. So this seems biologically plausible. There's probably a little bit of infection, but I think that a 3rd dose is going to be more helpful than a 4th. Both from what we know about immunology, the 3rd dose probably broadens immunity more because there was time for affinity maturation to occur. If that doesn't make sense to you, don't worry about it. But I think that will be less true for a 4th dose than it was for a 3rd. Also, the quantitative boost in antibodies is a little bit less impressive for a 4th than it was for a 3rd. So this is probably a little bit less helpful to see wild type spike for a 4th time. than it was to see a third. But like, again, if it matters to you, I told my parents who just went on international travel to get this fourth dose. They're, near 80 each of them. They've also not been infected. If you're someone who's seen 3 doses and an Omicron infection, maybe the battle is different. It also only briefly protected against symptomatic infection that waned back to baseline pretty quickly. Okay, your questions, most of which I've already covered. I will run through them quickly in the interest of time. We got several questions on vaccines for under 5s, and I think I mostly answered them. I'm frustrated by the delays too. I do want to see primary data, but I expect to vaccinate my kid. Again, here's a place where I'll say, you might reasonably ask, what if your kid has been infected, especially what if your kid's been infected with Omicron? And there, I think we're just stepping out of the data zone. I will say that that is not the situation I find myself in with my family. But in thinking about it, from what I've seen, there's enough breadth of immunity that happens with a second look at spike that I would tend to say yes, but you can't really look at data to defend that position. That's more of my gut feel on this. I think that it's unlikely to cause much harm. Should I mask on public transit? I choose to, and not only that, but, because of both case rates around us right now and poor ventilation on especially buses and trains. The CDC actually recently, just as recently as yesterday, restated a recommendation. They're no longer allowed to mandate this, but for masks on public transit nationwide based on rising case counts. And I would use high quality masks given that it's going to be one-way masking. And then lastly, I got one question specifically about a complication of a booster called chronic urticaria and whether that should impact decisions around the children of this particular person. I thought I'd try to, this is not something I have a ton of expertise in, but I was able to ask a colleague of mine who is an allergist who actually studies responses to the COVID vaccine. She says, first of all, this is a fairly well described phenomenon after these COVID vaccines, uncommon. It's in the thousands of reported cases in the US out of, hundreds of millions of doses given, but still, like, this definitely is a real thing. And probably she sure views it as probably heritable. So first degree relatives may be at higher than baseline risk. It's certainly not a guarantee that anything will happen, but it's hard to quantify how much. So I can't really give specific recommendations except to say it's something to think about. Maybe talk to your child's pediatrician. All right, so a speculative look ahead, and then I'll wrap up. I think we're going to see these kind of sequential variant sweeps and corresponding rises in case counts. I don't know for how long. And I think both how high they get and how often they happen remains to be seen. I'm sorry, that's sort of a bit of a cop out, but it's the best I can do. I think anyone who says more than that is certainly saying more than I'm willing to say at this point. I do think and hope that each wave is likely to have less of an impact on society because of immunity, but individual impacts are going to still vary widely. There's still hundreds of deaths a day from this. It's down in the 300s from 1,000, but as cases rise, it may rise from here still. It's not going to be sort of monotonically decreasing, but I think overall we're going to trend towards a little bit lower impact. 300 deaths a day is still a lot, right? That's still in the hundreds of over 100,000 a year. And we're at a lull. I don't think we can guarantee that it's going to continue going down, monotonically from here. Hospitals should be less overcrowded, but staff absences and disruptions are still a major issue, both in hospitals and sort of more society-wide. And remember that your own immune status really matters in how these viruses are going to impact you if you encounter them. Community protections don't work to prevent severe disease. They to some degree may help to prevent disease. Certainly community incidence, changes your effect of getting an infection, but contingent on getting infected, you can't get any protection from anything but your own immune system from severe disease. And so that's a really hard place that we find ourselves in. It is unclear to me how, as a society, our behavior is going to change going forward. I hope that we take this as a moment to improve ventilation in a lot of indoor public spaces, but we've not really made a lot of moves towards that yet. I don't know if we have the appetite to put masks back on if cases rise substantially from here, or if severity, returns in a way that we don't predict. And I don't know how often we're going to be asked to boost, nor how many people will update it. And I also don't know if something like Omicron is going to happen again. A lot of this above is predicated on like Omicron sublineages, but if there's a brand new variant, who's to say that can't happen? It happened once with Omicron, took us all by surprise, and I'm not ready to say that won't happen again. The issue of variant-specific boosters, right, which is sort of this huge promise of the mRNA vaccine platform. The FDA is going to consider this issue in June, and by the end of June, hopes to have some recommendations, some guidance around what it would take to approve those vaccines with an eye towards the fall. So I personally think Omicron is divergent enough and has been dominant for long enough that I hope this happens, and sort of expect it to happen, but have no real inside knowledge. That's just sort of gut from someone who's followed the field as closely as I have. And I think that just stay tuned for that. But it seems like fall is the soonest that would actually get rolled out. I haven't talked about it today, but treatments are available and getting more available all the time and work really well for high-risk people to prevent severe outcomes. But testing and a linkage between testing and treatment is really needed. So if you or someone you know is at high risk, that's a thing to keep in mind. Test early and talk to your physician early about treatments. And global equity, both around vaccine distribution and treatments, are still important. So just to summarize, it's becoming harder to track cases, which is unfortunate. It's harder to know what's going on around us just because more and more of the testing is being done at home or just not being done at all. Waves, despite that, they clearly continue. And this is mostly driven by immune-evasive variants, but also by behavior changes in society. I expect that each wave will have less of an impact on our population, but that's not necessarily something that individuals, especially in immunosuppressed individuals or those who have relatively less immunity for whatever reason, can necessarily count on. And this is an unfortunate combination, right? We are less and less able to keep track of how this disease is spreading around us, and yet being asked to manage risk at a more and more individual level. So with fewer tools to do that. But that is sort of the status, for better or for worse. That's where we find ourselves. Stay tuned about vaccines for kids less than 5. Also, boosters for kids 5 to 11 are going to be debated this summer. Fourth doses are now available for people over 50, especially valuable if you're at high risk. And then also stay tuned for variant-specific boosters. That is all that I had for today. I hope that was helpful, and stay safe out there, and I'll see you around the road.